Hello, everyone. We will get started in just a few moments. So thank you for joining us today. Hi, everyone. Good morning, good afternoon, and good evening. Thank you all very much for joining us today for the first session of Momentum's webinar series, Strengthening Analysis and Use of Routine Health Facility Data for Maternal, Newborn, Child, and Adolescent Health. We're thrilled with the great amount of interest in this topic and very happy that you're able to join us today. My name is Zach Crosser, and I am a Research Monitoring and Evaluation Advisor with the Momentum Knowledge Accelerator Project. Before we begin with today's session, there are a few housekeeping items that we'd like to cover in order to provide everyone with the best experience possible on today's webinar. Next slide, please. First, please note that today's webinar and all other sessions during this series will be recorded and posted to the Momentum website. So if you're not able to attend any of the sessions in this series, you will be able to access the recordings and materials shortly after each session takes place. During today's session and during several of the other sessions in this series, we will have presenters speaking in English and some will be speaking in French. We have simultaneous interpretation available for all the sessions in the series. I would like to now take a moment to allow you to select the interpretation icon at the bottom of your screen and choose the audio channel that you would like to listen into for today's session. If you stay in this main channel, you will hear the presenters speaking directly. About half of today's presentation will be in English and half will be in French. So I'd encourage you to click on the interpretation icon and select the language that you would like to listen to for today's session. On a related note, the slides that will be presented on the screen for today will appear in the language in which the presenters are speaking. My colleague Emily will share links in the chat to English-only and French-only versions of the slides that you can follow along with during the presentation. We'll aim to give verbal cues to note when we're progressing to the next slide. Lastly, there will be multiple breaks for questions and answers during today's session. Please click on the Q&A icon at the bottom of the screen to submit any questions that you may have. We'll do our best to respond to the questions either directly in the chat or verbally during our Q&A breaks. With that housekeeping out of the way, I think we are ready to begin. Next slide, please. The purpose of this series is to introduce participants to resources and tools that you can use to strengthen the analysis and use of routine health facility data for maternal, newborn, and child health in your work with country stakeholders. Routine health facility data is an important source of information for decision makers to understand service utilization and service quality so that they can identify programs and make evidence-based decisions on policies and resource allocation. In an effort to strengthen the analysis and use of health facility data for MNCAH programs, the World Health Organization developed a guidance document and an accompanying resource package that can be used in capacity strengthening workshop settings and webinar settings such as this one. The guidance document describes a catalog of indicators for MNCH that can be monitored through health information system data. And this document also provides guidance on possible analyses and visualizations for the indicators. The document also includes considerations for program managers for interpreting and using the data for decision-making. The Momentum Knowledge Accelerator project has adapted those WHO materials for this Training of Trainers webinar series. During the series, we'll dive into different components of the WHO toolkit to show participants how to access and use the resources. My colleague Emily will also share a link in the chat where you can access the guidance document in the accompanying resources. There's also a link in the slides that you can use to access the WHO webpage. Also during this webinar series, you'll hear about practical examples from Momentum projects to help illustrate how the concepts covered in this series can be put into practice. Next slide, please. Each session in this webinar series will have a similar structure and will include the same core components. We'll begin by introducing participants to key concepts related to analysis and use of routine health facility data. And as I just mentioned, we will also hear presentations from staff from different Momentum awards on how they put these key concepts into action in their work. Lastly, in each session, we will highlight different tools and resources. We'll focus largely on the WHO toolkit, but we will also highlight other key resources throughout the sessions. This is the first session of a 5-part webinar series. Today's session provides an introduction to health facility data, and we'll discuss the different types and sources of routine data. And we will also discuss key indicators for monitoring MNCAH programs and talk about considerations for introducing indicators into country HMIS systems. Session 2 will look at data quality considerations and also talk about approaches to improve data quality. That session will be held on Tuesday, August 13th. Session 3 will be held on September 5th and will focus on data triangulation and analysis. Session 4 is on September 12th and will look at data interpretation and data use for decision-making. And finally, our last session is on September 26th, and this will be a shorter session that will focus on data visualization. Next slide. Today's presenters include myself, as well as Barbara Rollins, who is a Senior Implementation Research Advisor with USAID, and Dr. Zaku Yahaya, who is a Senior Program Manager with the Momentum Integrated Health Resilience Project, or MIHR. Next slide. I know that we have quite a few participants today who come from outside the Momentum suite of awards, so I would like to provide a brief overview of the Momentum suite for context. Today's webinar is hosted by the Momentum Knowledge Accelerator, which is one of the 6 global awards that are part of Momentum. Momentum also includes 5 mission-issued awards that are working in India, Malawi, and Yemen. Momentum is USAID's flagship suite of integrated projects that work alongside governments, private and civil society organizations, and other stakeholders focused on making improvements in maternal, newborn, and child health, nutrition, involuntary family planning, and reproductive health. Using a more targeted, context-specific approach, Momentum works to strengthen the capacity of a myriad of stakeholders to create demand for, deliver, scale up, and sustain evidence-based interventions in more than 40 partner countries around the world. You can find more information about the Momentum projects at usaidmomentum.org, which is linked in the slides. Next slide, please. I will now hand it over to Barbara for a few remarks on the relevance of the WHO toolkit to the Momentum suite and to USAID. Barbara, over to you.
Thanks so much, Zach. The WHO guidance and associated capacity building materials that we're using in this series help to address a couple of key gaps. I think, first of all, there's been a lack of global consensus around what priority routine maternal and child health indicators to monitor through national routine health information systems. And there's also a need to improve data competencies among data users at multiple levels of the health system, including competencies in things like data analysis, visualization, interpretation, and data use. And these resources help to address these gaps by presenting a catalog of recommended indicators, along with guidance on how to analyze those indicators, and then the capacity building materials, which include some really helpful exercises. And USAID recognizes that availability of high quality MCH data at the right time and place for use by decision makers is absolutely critical to helping to accelerate progress towards our prevention of child and maternal death goals. So with that, I will turn it back over to you, Zach, and really looking forward to this series. Thanks.
Thanks, Barbara. Next slide, please. During today's session, we'll introduce you to the WHO guidance document and a few of the companion resources. We'll also provide a brief introduction to WHO's recommended MNCH indicators that can be calculated using routine health facility data. In addition to this, we'll describe how these MNCH-specific resources fit into a broader WHO toolkit for routine health information systems. During the second half of today's session, we will hear from the Momentum Integrated Health Resilience Project about their experience working with the Ministry of Health in Niger to advocate for maternal health indicator inclusion in the routine health information system. Next slide, please. When we think about the different types of health data within a health information system, we can conceptualize them broadly into two different categories: routine data and non-routine data. Some of the different sources of routine data are things like health facility service utilization data, which comes from the Health Management Information System, or HMIS, commodity stock data from the Logistics Management Information System, or LMIS, disease surveillance data, community-based data, civil registration, and vital statistics are also considered forms of routine data. And lastly, routine data also includes data about human resources and financing and health expenditures. Non-routine data, on the other hand, refers to things like surveys, such as health facility assessments and population and household surveys. The SPA, DHS, and MICS are some of the well-known surveys. Non-routine data also includes things like modeled estimates, such as estimates of stillbirths and child mortality that are produced by the UN Interagency Group for Child Mortality Estimation. And all of this information together in a health information system helps to guide the delivery of health service programs. Each of the different types and sources of health service data serve a different purpose and have their own advantages and limitations. Next slide, please. The WHO guidance document, as well as this webinar series, are really putting a spotlight on routine facility-based data. So this type of data are data on services that are provided at clinics, hospitals, or other service delivery points at a given period of time. The system of regular recording, reporting, analysis, presentation of health facility data is known as the Routine Health Information System, or RHIS. This is an acronym we'll hear a lot throughout this webinar series. The RHIS provides a picture of the services delivered in health facilities and the status of the people using the services. This can be used to assess the performance of an individual facility and also to assess service utilization and coverage of interventions in defined populations. RHIS data serves multiple users and a wide range of purposes, including patient and facility management, disease surveillance, resource allocation, and policymaking. Data reported through the RHIS may be referred to as RHIS data, routine health facility data, or simply routine data. A defining feature of RHIS data is that they're reported regularly, usually in monthly or quarterly intervals, but sometimes those intervals may be periods of up to 1 year. When we refer to the RHIS, this may be a paper-based system, an electronic system, or more likely a hybrid of both. In many health systems, aggregate data from monthly reports are entered into an electronic database, such as DHIS2, with that data entry process usually taking place at the health facility or maybe the district level. In some routine health information systems, aggregate data from all programs are entered into the same electronic system. In other cases, specific programs have their own separate systems. So the configuration of the RHIS can vary greatly from country to country. One of the main advantages of RHIS data is that it is collected continuously and analyzed regularly, and can therefore provide up-to-date information on health services and on health conditions occurring in the populations using the services. This allows for early identification of problems and enables managers to take timely actions. Another advantage is that the RHIS supplies data representing subnational, district, and facility levels, which allows us to monitor programs with a high level of geographic specificity. Lastly, the RHIS can be customized to calculate indicators to fit different use cases, such as using a facility-based denominator versus a population-based denominator. In terms of limitations, health facility data can really only provide information on the people that use the facilities. So we're not able to understand anything about the populations who don't have access to facilities or who choose alternate care options. The RHIS also doesn't really give us insights into the demand side of health service utilization, such as the knowledge, attitudes, and behaviors of clients. And lastly, the quality of RHIS data is often a concern. Data quality issues may arise due to missing data, over or under-reporting, data entry errors, or other issues. And we'll look more into data quality considerations during session 2 of this webinar series. Next slide, please. So just to look a little bit more specifically at some examples of how the routine health facility data is used, we can see that this type of data is widely used for health sector reviews and program planning. It often forms the basis of national reports of health statistics, and it's used to assess health programs at all levels of the health system. It can also be used to identify trends and make comparisons across key populations, and it can be used to estimate coverage of interventions at the population level. Or it can be used as an input for modeling to estimate population denominators for certain indicators. Next slide, please. So we've established a basis on just helping to make sure we all have a common understanding of what we're referring to when we say routine health information systems and routine health facility data. And now we're going to pivot a little bit and talk about some of the WHO guidance and its companion resources. Next slide, please. So the purpose of the analysis and use of health facility data guidance for maternal, newborn, child, and adolescent health program managers document, which was released in November of 2023. So still less than a year old at this point. The purpose of this document is to help MNCH program managers understand this core catalog of MNCH indicators that can be reported through the RHIS. The document also includes guidance on basic analyses and visualizations of the indicators and on using the data for decision-making. The intended audiences for this document range from across MNCH stakeholders, from Ministry of Health staff who are working on program implementation or monitoring and evaluation activities, to staff of partner organizations who are involved with supporting MNCH programs or with health system strengthening. We want to pause for a minute. We have a poll that I'm going to activate with just a simple question. We want to know, before this webinar, were you familiar with this guidance document? Yes or no? So we just want to see, is this something people have heard of before? Okay, I'm seeing we're getting a lot of responses in, and it looks like maybe about 3/4 of our audience was not familiar with this resource before the webinar series, and about 1/4 of people had heard of it before. Great, that's interesting. So hopefully those of you who were not familiar with this guidance document will learn a lot from this webinar series. And for those of you who were familiar with this guidance document, hopefully we can go a little bit deeper in your understanding. Next slide, please. Despite the importance of routine health facility data and substantial investments in RHIS over the years, many contexts have continued to face challenges related to RHIS data. These types of challenges have included needing to report on a large number of indicators, a large number of data elements, and many different disaggregations, and a lack of standardization across indicators. There has also been a fragmentation and duplication of data systems that lack interoperability. Poor data quality has also resulted in a lack of trust in RHIS data. And there continue to be capacity gaps in people's ability to analyze, present, and interpret routine health information system data. So in response to all of these challenges, WHO has led the development of a broader toolkit for analysis and use of routine health facility data. The toolkit emphasizes standardization, integration, and a focused approach to data analysis. It aims to focus the analysis of RHIS data on a limited set of standardized indicators, using recommended standard analyses, visualization, and dashboards, and also to provide guidance on data interpretation and use. The guidance on analyzing and using facility data for MNCH specifically is just one component of this broader WHO toolkit. Next slide, please. While the guidance document that was developed by WHO on monitoring is important for providing evidence-informed measurement standards, WHO also recognized that the guidance document itself is not enough to promote data use or to create a culture of data use. So in an effort to more sustainably improve the quality and use of data for decision-making, WHO also created capacity strengthening materials to accompany the guidance document. You can access these materials using the link that was shared earlier. They're available for you to use in your work with partner organizations to introduce them to the catalog of MNCH indicators from the WHO guidance document, to review concepts and methods used to assess the quality of RHIS data, and also talk about approaches for analyzing it. Lastly, the capacity strengthening documents serve to build capacity to interpret and use the data for decision-making. The accompanying materials consist of 7 presentation modules, along with companion exercises for participants to complete in workshop settings to give them a little bit of hands-on experience to better understand the concepts. And there's also a facilitator guide. One other thing to note with regard to these capacity strengthening documents is that the D4I project, along with GemNet Health, is in the process of adapting these capacity strengthening materials for a web-based e-learning course that will be available in the WHO Academy in 2025. This undertaking comes with support from Global Health Pearl, And the interactive course will provide an overview to the key concepts from the capacity strengthening materials and will include training on using the MNCAH indicators. So keep an eye out for that resource that will be developed and released next year. Next slide, please. So during today's webinar, we will be looking at the first two presentation modules of the WHO toolkit. These two modules cover the types and sources of health data and also introduce us to the WHO catalog of MNCAH indicators. Next slide, please. So now we'll begin by looking a little bit more closely at presentation number 1. Next slide. The first presentation in the WHO toolkit focuses on fundamental concepts related to the health information system. It covers the types and sources of data in the health information system and looks at the differences between routine and non-routine data. It also discusses the advantages and limitations of each. It outlines key sources of data for MNCAH. And you may notice that some of those first 3 bullet points are actually topics that we have already covered in today's presentation. So the slides that I presented earlier are actually adapted from this first part of the WHO toolkit. And so now we'll have a few slides where we'll be able to dive into a little bit of the rest of what is contained in presentation number 1. Next slide, please. So later on in presentation number 1, you will find slides that discuss the purpose of routine data collection and reporting. They include infographics that help to illustrate how data is collected and aggregated. So beginning at the facility level, and then that data gets reported to higher levels, such as the district, subnational, and national levels. Next slide, please. There are also slides that include example illustrations of how data flows through the RHIS, beginning with the provision of services to clients, and then having those interactions be recorded in medical records or registers. And then those records are aggregated and entered into the RHIS for reporting. Next slide, please. As health workers go about their daily work of delivering care, they record data in various tools and forms. Presentation number 1 provides examples from some of the various tools and forms that are used to collect and record routine health data. So data might be recorded on individual patient records, files, prescription cards, or immunization records. The health facility may also collect routine data in tools such as registries, tally sheets, logbooks, stock keeping records, and financial records. This slide includes pictures of just a few of those different types of records and forms. Next slide, please. Selected data from those records and forms are then extracted from patient records, aggregated in tally sheets, or counted from registers. And then all of that information is consolidated in monthly reports. The reports are then submitted at regular intervals through the RHIS to successive levels of the health system, where the data is then further aggregated and analyzed and used. Data may need to be aggregated and reported weekly for potentially epidemic diseases, monthly or quarterly for medical health activities, semi-annually for program monitoring, or annually for summaries. Next slide, please. Presentation number 1 concludes by driving home the point that the raw data that is collected must be organized into a usable format, such as an indicator, in order to be used to monitor and assess programs. The information that we get from indicators can then be analyzed, communicated, and acted upon. So overall, presentation number 1 is a good resource for helping to understand the fundamentals of how data collection and reporting forms and processes generate data elements that serve as numerators and denominators that are used to formulate MNCH indicators. Next slide. Another great resource for helping stakeholders to understand the routine health information system is Measure Evaluation's Routine Health Information System curriculum. This curriculum was developed several years ago, but the basic concepts that it covers are still applicable in today's context. The resource package consists of 10 training modules with presentations and practical activities, as well as a facilitator's guide. A link to these resources is available in the presentation slides. Next slide, please. And now we will dig into a little bit of what we will find in presentation number 2. Next slide, please. Presentation number 2 is where we're introduced to the catalog of recommended indicators for MNCH. And more importantly, this presentation includes a mapping template that allows countries to map the WHO indicators against what's already being collected in their routine health information system, so that they can understand how you would go about thinking about adding different indicators to your routine health information system based on what you have and what's feasible with your reporting tools and forms. Next slide, please. The WHO indicator catalog groups the indicators into 4 categories. The first is a series of indicators on contacts with health facilities across the MNCH continuum. The second is a group of indicators that covers the content of care during the antenatal, childbirth, and postnatal periods. The third group of indicators covers specific interventions during childhood and adolescence. And the last group of indicators covers institutional mortality in stillbirths. For each of the indicators in the catalog, the guidance document gives a specific definition, a numerator and a denominator, and suggested disaggregations. The MNCH indicators that are recommended in this guidance document are aligned with relevant indicators from other WHO RHIS toolkit program modules. So you can see some of those other modules displayed at the bottom of this slide. Next slide, please. The guiding principles that were used to select the catalog of indicators included making sure that the indicators are applicable to women, newborns, children, and adolescents who are seeking care in health facilities, that the indicators measure evidence-based practices in interventions, that the indicators are relevant across all levels of the health system, and that they're based on aggregated facility-based data. Next slide, please. The recommended denominators for the indicators are mostly facility-based, but for some indicators, population-based denominators may be relevant. It's acknowledged that some of the indicators included in the catalog may not be relevant in all settings, and in some settings, it might not be feasible to report on certain indicators or disaggregations because of the way that the health information system is configured. For these settings, the guidance document recommends considering updates to the data collection or reporting tools in order to allow for the appropriate data elements to be collected. Next slide, please. So using those guiding principles, a catalog of 31 indicators was selected. Because that full catalog may not be feasible or relevant for reporting in all settings, WHO also selected a minimum subset of 15 indicators for program monitoring. The criteria for selecting this minimum subset included ensuring that the indicators represented activities from across the MNCH continuum, ensuring that program managers could take action based on the information that they received from the indicators, and ensuring that the necessary data could be collected through existing RHIS configurations. Next slide, please. So the 15 indicators that were selected for this minimum subset cover ANC contacts, ART coverage, facility births, cesarean sections, low birth weight, early initiation of breastfeeding, PNC for women and newborns, third dose of DTP, child growth monitoring, acute respiratory infection, HIV, HPV vaccination coverage, contraceptive commodity distribution, institutional mortality in stillbirths, and completeness of facility reporting. We don't have time today to dig deeply into these indicators, but I recommend reviewing the indicator definitions, computations, and recommended disaggregations that are provided in the WHO guidance document. Next slide, please. Another great resource that we would like to highlight is the Momentum Monitoring, Evaluation, and Learning Framework. This document is available on the Momentum website, and my colleague Emily will be sharing a link to how you can access this document in the chat. The MEL framework describes the momentum theory of change, the learning agenda, its measurement, analysis, and synthesis approach, as well as the suites approach for dissemination and data use. This document includes an appendix with recommended indicators for momentum awards. These indicators are very closely aligned with the catalog of WHO recommended indicators that we just reviewed on the last slide. This document is an excellent resource for momentum and non-momentum staff alike, and we encourage you to check it out. Next slide, please. So presentation number 2 concludes with considerations for integrating indicators from the WHO toolkit into national systems. In general, the process should begin with comparing the indicators in the WHO guidance to the indicators that are currently reported in the national system. Specifically, we want to compare the numerators and denominators, and also to take note of any similar or proxy indicators that are currently reported in the national system. The next step is to review the data collection and reporting forms where the data elements are captured, so that we can understand if the necessary data elements can be captured and reported, and from which registry they would be reported. The third step is to consider which indicators can or should be added to the national system, and also to consider how they could be added. The WHO toolkit, as I mentioned earlier, contains a mapping template, an Excel file that you can use to complete this type of exercise. Next slide, please. If an indicator is not, after you undertake that mapping exercise, you find that an indicator is not currently reported in the national system, but the necessary data elements are, you would need to coordinate with the Ministry of Health to identify when the national indicator catalog will next be updated and request for that indicator to be added in the next update. If the indicator or necessary data elements aren't in the national system, but they are in the existing data collection tools, you would need to coordinate with the ministry to see if those data elements could be aggregated from the existing tools and included in the RHIS. And then lastly, if the data elements are not being captured in existing tools, you would need to understand when the tools will next be updated and advocate for them to be modified so that they can capture the necessary data elements. This sort of undertaking would likely require a pilot testing period at a district or subnational level before those type of changes are rolled out more broadly. All of this, of course, is a simplification of what this indicator integration process looks like. For the remainder of today's session, we will hear from the Momentum Integrated Health Resilience Project about their experience advocating for the introduction of indicators into the RHIS in Niger. Next slide, please. However, but before I turn it over to Dr. Zaku Yahaya, we will pause for a moment for Q&A.
Great, thank you, Zach. There are a few questions in the Q&A so far. We've answered one of them through text, but I just wanted to answer, I think, one of them live as well. Didit asked if there are any best practice countries in Asia with momentum. I believe that have used WHO's implement their MNCH programming with WHO tools and routine health information systems. And I just wanted to note that MRIT, Momentum Routine Immunization Transformation and Equity, I think, project, will be presenting in the next session, in session 2, around experience with immunization data quality in India. I don't know that they have the degree to which they have used the toolkit, but they will be talking about their experiences with routine health information systems in India. And I see there's a question about how do the catalogs contribute to the most needed improved quality of care. Barbara, do you want to come off mute and answer that one live?
Yeah, sure. Thanks. I was just starting to type an answer. I think from my perspective, the catalog includes content of care indicators that relate to key high impact interventions across the MNCH spectrum that need to be implemented with high quality, effective coverage in order to achieve mortality reduction. So I think that there was a specific effort to align indicators where possible with trying to track those priority interventions. Thanks.
Thank you, Barbara. I see there are a few more questions, but I also know we need to stick to a schedule. So we'll work on answering those questions in the Q&A section and hand it back over to you, Zach.
Thanks, Emily and Barbara. Next slide, please. So now I will hand it over to Dr. Zaku Yahaya to talk a little bit about MIHR's experience with indicator integration in Niger. Before I hand it over, I would also just plug a reminder for if you have been listening to this presentation in the main channel, that we will be switching languages now from English to French. So if you would like the interpretation from French into English, please go ahead and click on the interpretation icon at the bottom of your screen and choose the English channel. So with that, I will hand it over to Dr. Zaku.
Merci beaucoup. Bonjour à tous. Donc, je vais vous présenter.
Thank you very much to all of you. I'm going to present. So I'm going to talk about the Momentum Integrated Health Resilience Strategy for Early Distribution of misoprostol for the prevention of postpartum hemorrhage. And so the opportunity to introduce uterotonics and misoprostol indicators into the national HMIS system, which is the Health Management Information System. I am Zahu Yakaya, and I am part of the team that works on the project Momentum Integrated Health Resilience. Next slide, please. So we're going to follow the following agenda. We're going to start with the introduction, and then we're going to talk about the Momentum Integrated Health Resilience interventions, the results and the lessons that we learned, as well as the challenges and the approach that we've used for the MIHR advocacy with the data that we have. So we're going to talk about the context in a general context, and so the recommendations of the WHO on the use of uterotonics, so which is an essential drug that is used to prevent postpartum hemorrhage, and is also used for other things as well, but we're going to talk about its role to prevent postpartum hemorrhage. And it is recommended by the OMS and the in health facilities where the oxytocin is not available. And so oxytocin is recommended, but when oxytocin is not available, we could use misoprostol to prevent postpartum hemorrhage. Misoprostol can be used by community health workers and non-professional health workers for the prevention of PPH in settings where trained health personnel are not present to administer injectable uterotonics. So there are several challenges associated globally with the early distribution of misoprostol for home delivery or home birth. And so that would be the drug abuse of medication, premature intake of this product, or used to induce abortion, or a lack of ability to diagnose multiple pregnancy after of the fetus. And so misoprostol is not registered for use in the country, and as well a lack of guidelines and training for healthcare providers. And sometimes there's limited knowledge at the community level of misoprostol and as well its use and its importance. So next slide, please. Well, so in the context of Niger, we must note that it is important to give birth at home. In terms of it is 63%. It represents they give birth at home without the help of qualified personnel, and only 32% of pregnant women make at least 4 antenatal or prenatal visits. And so it is very, postpartum hemorrhage accounts for almost 7% of maternal deaths. And so that is the statistical data. That's what it shows. Slide. Next, please. So there are several elements that affect the distribution of misoprostol in terms of Nigeria. And notably, rumors or incomplete information on the proper use of the drug, and mothers can confuse misoprostol and sulfadoxine with other products that they use for prevention. And caregivers, they doubt the patient's ability to keep the drug safe and to take it at the right time. And as well, the supply does not seem to be a problem, but this really depends on the donors. And so we have found that the experience that has been approved, the availability, and that was present, that was made up, it has contributed to a availability problem in terms of the training, national training and health training. And religious culture and social norms contribute significantly to poor indicators. And so the usage of these products and peripherically, but it is the current situation. The situation was exacerbated by the current situation in Niger with the coup d'etat in July 2023. And so USAID Momentum in Integrated Health Resilience has supported Maternal and Child Health Directorate to train health workers and stakeholders and advocate for the distribution of misoprostol for home use. And so in the case of births, that is assisted by a non-qualified health personnel. Next slide, please.
Next slide, please.
And so what are the interventions of momentum integrated health? And so in the 4 health grid districts, we've had a process of training, adaptation, and of the mother and the kid, and the identification of sites, health facility level. And so 71 health facilities that cover. And so we have had a training that is organized in each district, which was facilitated or led by a DSME staff with the support of the MIHR team. And so that would be the regional management of public health and the social affairs, depending on the intervention, and train health care providers to organize ongoing awareness sessions at the facility level for the mothers who come to train about prenatal CPN during the 3rd trimester. And the continuous data collection at the health facility level. And so there needs to be a part of the training that is the data, is about the data, the distribution, as well as that is consists of data collection, complementary. And if we have this type of distribution type of training on the misoprostol in DOSO. Next slide, please. And the health workers, they begin distributing in several health facilities after this intervention. And so with misoprostol, not with just conscientization, but also that they could benefit from the training for mother and kids that is done by the integrated health. And so that would allow them to help have activities and carry out at the CPN at the last trimester. And as well, for sure, the implementation of data collection tools in health facilities, which are already pre-collected and that consist to register all the women that use misoprostol after birth, or those who also go through health training with misoprostol. Support for the implementation of distribution plans by target IHC, and so to be able to continue with the sanitary district, and after that to have training. We have a training process that is more recent who have not, for those who have not started to distribute. And so we're going to see that later on. We're going to see an example at the Tawa distribution. So training of health on early distribution of misoprostol in Tawa. Next slide, please. So we have a support for demand creation at a health facility and at the community level, and implementation of community actions. And so that is without so letting them know about it, as well as about this possibility, particularly for women who give birth at home, and how dangerous postnatal hemorrhage is at the community level, and the best place to let them know where the best place is to give birth is the birth, and if they have to go outside or without a qualified health personnel, they would need to use it after it comes out of the fetus. and the mobilization and training of community health workers, peer-to-peer awareness with community health workers, and integration of leaders who are mothers in terms of the awareness of misoprostol use. And so it's in Nigeria, the distribution is only at the sanitary level. And so it's only the healthcare workers right now for distributing misoprostol. And so that could be through a community. And just right now, it's only at the level of training at CPN in the last trimester with awareness at the community level. And this will help the community and pregnant women to know the importance of misoprostol and where and when to get misoprostol for use during a home birth. Slide. And so we're going to see what the lessons that are learned and as well the results and what has been learned, what we've been able to take from this experience. Slide. So during the process that started in 2023, we recorded 12,000 women who benefited from the awareness of using the use of misoprostol. A little less than 4,000 that were pregnant, and according to the women who use misoprostol, 800, a little more than 2,000 used misoprostol between 1,400 who brought that was not used misoprostol, and those who had not. We have also a high number, but close to 12% who did not bring misoprostol. And so that constitutes an element that must be noted because we need to keep raising awareness about misoprostol, because every time that it's not used, it needs to be brought at the level of a sanitary, and they need to come back to see whether we need to find out whether she used it or did not use it in the setting and for she and her child. Next slide, please. So what are the lessons learned? So we learned that the involvement of the Ministry of Public Health, Population and Social Affairs at all levels, especially at the central level, at the mother and the child at the level, the health ministries of public health, as well as the maternal and child health, they both facilitated the implementation of misoprostol distribution for home births. The absence of data, misoprostol data, in district health information software too, it had a negative impact on data completeness and timeliness, because it was more work to the personnel, health personnel, to collect this data instead of just being able to extract them and use them. And so it's made it difficult to monitor the distribution and use of misoprostol in the community. And the advocacy at various levels and active involvement, the country health information systems and data use, it made it easier to obtain Department of Health agreement in order to integrate the new data into DHIS2. And so we must take into consideration these tools as well as the integration next time to look at the data, review the data, because the data implicates that we need to take time to review it. So we are waiting for the next data or the data in the future. And so I was saying advocacy at different level is having acceptance, and to having at the beginning, Shisu to be able to advocate this for the integration of data and the indicators of misoprostol. And it is important to note that the border closures that followed the coup d'etat in July 2023, it had negative impacts on the availability of products in health facilities, especially misoprostol. And that's led to an actual drop, a drastic drop in the distribution of the product. In all the in the information, the health information, health data. Next slide. Next slide, please. And so here we have at this beginning of this activity in April of 2023, there was a tendency to have a very weak distribution. And so during the 6 months of the availability, and as soon as with the difficulties in distribution, we saw that there was a very low tendency. And that is because of the non-availability of misoprostol with sanitary data in terms of the data. And so we're starting to deploy it in other regions, misoprostol, so that it can be used in training. And so this shows the impact of the borders as well as the missing in product introduction as well as the closures and how it affected misoprostol distribution. Next slide, please.
Next slide, please.
So the challenges is the availability of misoprostol. I know that it they were not it does not constitute a problem. It was to bring this activity. We observed that months after the coup d'etat, and the indicators for monitoring misoprostol distribution are not available in the RHIS platform. And particularly regular input of the misoprostol indicators would enable stakeholders to access them easily and to continue with their, or to ensure regular monitoring of their correct use. So the data collection by district focal points with the indicator framework for health providers, the process is consistent, it's time consuming, it makes it difficult to be able to have up-to-date data. And at the institutional level, tools that help raise awareness need to be updated. And training material also needs to be updated. So with the updating, and that needs to take into consideration the tools, awareness tools, and the directory of health for maternal and kids. They put some algorithms and some awareness tools that are at the disposal to be able to continue this process of distributing misoprostol in the community, and those are still being disseminated in terms of the different training levels. So what is the approach for the integrated health? And we were engaged, we talked with the districts and the DSRP to have meetings to show the scale or the scope and necessity of having uterotonics in DHIS2, including misoprostol, and to adhere to this. and to gather the opinions on the procedure to ensure data collection, to gather recommendations from the different partners, to engage other partners, to talk with only one voice, and one phase of discussion to be able to, and so that that is being done. And we've also talked about the different indicators for the updating and the integration, and share that and take those indicators into account, the misoprostol indicators, as well as monitoring DHIS2 integration, the implementation, the integration of misoprostol data in DHIS2. Next slide, please.
Next slide.
And so what are the results of these different conversations? It is not very efficient, the data, in terms of especially collecting from the Ministry of Health, and to assure collecting data in a general fashion that is not very effective, because there has been data that has been missing, as well as with the district, the sanitary district, to make sure that, and to engage them in the prevention and management of postpartum hemorrhage, to gather recommendations from the department to understand why collection is not effective, and to having a list. So results of the meeting include discuss with CHISU to compile a list of indicators to be integrated, to decide on a single point of contact to discuss the issue of data integration, because it is a process, and it is a process which, when we have better integrated data, because we can't take all the requests of the integration, and so to be able to have one single voice being accepted by the ministry, and that to be able to integrate these aspects in DSIH2, and plan regular follow-up meetings and meet with the Department of Health to agree in principle with integrating data in DSHS2. And so the misoprostol indicators, there are misoprostol indicators that exist already. Indicators. There's a page that is there's a resume, the awareness in these different themes that have been developed to benefit the awareness. So there have been a number of pregnant women, who became aware of the use of misoprostol during home birth, that are having birth at home, who received misoprostol. But we want to know also the number of women who gave birth and returned misoprostol to the health facility, to know who gave birth at home and who did not return misoprostol to the health facility. And so these indicators, next slide, these were talked about from the WHO that was written. And so having the different indicators, as well as the numerators and the denominator. So you have the women that were aware and that were benefited from MNCAH, the number of women who were aware and that were pregnant, who benefited from a ANC3. The verification force was the IHC, which is the Integrated Health Center, who communicates health information as well as the IEC, Information, Education, and Communication, and IHC. And the number of misoprostol, one indicator is number of misoprostol tablets distributed per month, as well as the number of misoprostol distributed for PPH prevention. And the verification sources that we used were ANC, antenatal consultation register, as well as the IHC follow-up sheet. And the indicator is number of pregnant women who receive misoprostol for PPH prevention, and the numerator is number of pregnant women who received misoprostol for PPH prevention. And so this allows the women how many births that they have had at home, what is their percentage, it's who has used the misoprostol for using, and it is people who are healthcare personnel during the birth, and those who did not return the misoprostol. And so that allows them to see the women who had not returned the misoprostol. And so there we go, RCO follow-up sheet and IHC follow-up sheet. And the usage of misoprostol and the for the resilience, health resilience, to have them participate, to be able to have the integration and have these indicators of DSH2. Next slide, please. The end. Thank you very much. See if you have any questions, do not hesitate.
Thank you so much, Dr. Zaku. That was a wonderful presentation. Lots of really rich information. And we have a number of questions in the chat, or excuse me, in the Q&A that I would like to put up to you. So one of them that I think is really important that Barbara answered in the chat already, but I'd like to pose it to you as well. One participant makes a great point about the burden of adding more indicators to information systems and the possibility of over measurement. And that person asked, you know, should all indicators in the WHO guide be added, or, you know, is it up to the country's Ministry of Health and institutions to decide what indicators to prioritize given the measurement costs versus potential for impact? So just would love to get your perspective on the ministry's role in deciding what goes in, and yeah, any thoughts you might have on that. Thanks.
Merci beaucoup. Je pense que j'avais déjà signalé cette question.
Thank you very much. I think I already answered that question, taking into account the request of everybody regarding the data. What we need to know about postpartum hemorrhage, the burden of the delivery at home in Niger, what is the impact in terms of data to gather those kind of information, and also the engagement at the facility level to know that we can prevent the HPP and use it for prevention when we have delivery at home. In my opinion, we need a reasonable balance between the advantages, the advantages and disadvantages when we talk about gathering this level of indicators. But we know that the burden of HPP in Niger, considering the level of delivery at home, this could really have a great impact in the Niger health system. This is why the discussions were very deeply led with the Ministry of Health to really come to an agreement on this aspect.
Wonderful. Thank you. The next question, there was a question about, and this is more about kind of resources you might have to share. If there was a baseline study conducted before the introduction of misoprostol that you all did, and if there was any kind of report or publication that came out of that that could be shared.
Merci beaucoup. Je dirais
Thank you
pas
very much. Not a study, but an analysis of the health facilities to understand what is at stake, what are the drivers and of the misoprostol at the facility level. So this will be included in a PowerPoint or presentation developed with a few colleagues to show all the indicators and show also the risk level and what could be the framework in terms of use of the misoprostol. But this was a study specifically.
Great, thank you. Let's see. I think another question that we have is what interventions did you use in increasing the awareness around misoprostol and proper use with the mothers? And if you had any tools that were used for that. I believe you're still on mute, though.
Sorry. Donc, je disais que
Sorry. So I talked a little more of the technique that we call lead mothers for outreach and visit at home. And we also have different approach with a working group to support the nutrition of the newborn, and we work with the Ministry of Health. We have more than 2,000 lead mothers on site who are supporting all these activities, and this really helped for the outreach to these potential mothers. We also have a first-time parent approach, which is another tool to encourage the use of misoprostol. We also have different outreach activities with visit at home, community work, and we have an integrated module for the prevention of all aspects of the delivery and the disease related to delivery, not attended delivery. So we're trying to promote all these activities and which are part of our outreach framework for the use or the best use of misoprostol. So this is what I can tell you about the tools and approaches that we use to improve these outreach and raise awareness in this on this topic.
Wonderful, thank you. Another question that came in asking how often are tools revised in Niger and the duration of the project, and then a follow-up question. I assume maybe that means indicators within the routine health information system. But then the follow-up question is, if these indicators are already in the Ministry of Health's indicator catalog.
I'm not sure if this question is for me. Is it for me?
Yes, please. Let's see, the duration of the project of MIHR, and then a question is whether or not these indicators are in the Ministry of Health's indicator catalog. I assume they're referring to the misoprostol indicators.
OK. OK, merci beaucoup.
Thank you very much. So what we can say about that is that the distribution of misoprostol in the follow-up registry and of pregnant women, we have the distribution of misoprostol. So we do have data at the Ministry of Health level. But the DHIS2, it is at this level that the flow of information of data is insufficient. So we need, nevertheless, those information in those registries to know what is the reach of the distribution at the facility level and the use at the individual level. We already have some information in the registry at the prenatal consultation level, but as I said, it's at the DH2 level that we still need to work. I don't know if I really answer your question. Wasn't really clear for me, sorry.
No, I think that's great. Thank you, Dr. Zaku. And then I think maybe one of the final questions is around the role of the private sector in this providing data on misoprostol, and your experience potentially engaging the private sector in this work, or any thoughts you might have about that.
Bon, de par mon expérience,
based on my experience, the private sector in Niger is really have some challenges to offer and give us some quality data. So we do not really engage with the private sector, but nevertheless, we do have some activities with the private sector focused on the family planning. This is where we work with the private sector. We haven't get many results of impact so far, but we do think that we will be able to improve the data collection at some point. So we also have some activities with the private facilities, and we do hope that we will gather more information, quality information, but this is still a challenge in Niger. I have to recognize it.
Wonderful. Thank you. I think that concludes our Q&A section. Thank you, everyone, for your wonderful questions. We'll do our best to look through any questions that weren't answered and try to respond to those by email or after the session. With that, I think I will turn it back over to Zach. Thank you.
Thanks, Emily. I just want to thank Dr. Zaku and Barbara for joining us today and providing your really insightful inputs and comments. I think this has made for a really interesting and engaging session. And I want to thank all of the participants for joining us today and for your really thought-provoking questions. Next slide, please. So just before we end for today, I want to remind everyone that this was the first session of a 5-part webinar series. So we encourage you to join us for the subsequent sessions and the remainder of the sessions in this series. The next session will take place on August 13th beginning at the same time of day that this session did. And that session we'll talk about data quality. Next slide, please. And so that is all we have for today. We will conclude this session. Thank you very much for joining us.